We are again continuing the lecture on how palliative care is delivered. This presentation has been prepared by Dr. Mona Rai, Assistant Vice President of National Association of Palliative Care for Ayush and Integrative Medicine. We can see the quote, palliative care is when you feel the pain of others and try your best to treat every broken aspect of a sufferer, not a patient. Dr. Rajat Kaundal. From birth to final days of life, the circle is moving. So, the primary health care covers the majority of the person's health needs. We can see promotion, prevention, treatment, rehabilitation and the palliation, and the circle goes on. What is the scope of palliative care services? Again, right from birth unto death, we have healthy years at risk for chronic diseases, then the chronic illnesses set in, and we have chronic serious diseases in years resulting in death. Modern medicine is in pursuit of cure. Once diagnosed with chronic serious illnesses, increasing symptoms related to serious illness progression, there is a decline, and finally, hospice or pursuit of care is the answer. So, in pursuit of cure with care, it is life with hope for symptom free days. That is what is being targeted through palliative care, because there is always a physical decline when we grow up. Why palliative care? Palliative care alleviates suffering and improves the quality of life. Palliative care is cost effective and affordable, relieving the need for unnecessary hospitalizations and ineffective medical interventions. It is estimated that 61.5 million people experience serious health related sufferings worldwide. Poor people in all parts of the world live and die with little or no palliative care or pain relief. By definition, palliative care is a core component of universal health coverage and a key element of quality of health care. Children in need of palliative care face tremendous barriers to access, and removing these barriers must become a priority. So, palliative care offers physical support, psychological support, spiritual support and social support. They are the roots of palliative care. Whereas, the daycare services, the OPDs, the IPDs, home based care and hospital palliative care are the end results. Criteria for referral to palliative care. Now, cancer diagnosis, stage of disease is very important. Prognosis as per NCCN guidelines less than 6 months. Physical symptoms, Edmonton Symptom Assessment Scale on 10-point. Performance status, the National Comprehensive Cancer Network guideline used a Karnofsky performance scale score of less than 50%, Eastern Oncology Cooperation Group score of greater than 3 as cutoffs. Palliative performance scale scores of less than 60%. Psychological, NCCN guideline recommended a distress score of 4 out of 10 on distress thermometer. End of life care planning, discussing advanced care plans, enhancing illness understanding and prognostic awareness, exploring further treatment options, establishing goals of care and transitioning to hospice care. Who all are eligible for palliative care? Patients with cancer, chronic heart failure, chronic obstructive pulmonary disease, AIDS, Alzheimer's, neurological conditions such as multiple sclerosis, amyotrophic lateral sclerosis and many other serious illnesses are eligible for palliative care. India, unbearable pain. The India's obligation to ensure palliative care is enormous, says Human Rights Watch Group. Most common symptoms in palliative care are pain almost in 84% patient, easy fatigue in 69% patients, constipation in 52% patients, dyspnea in 50% patients, sleep problem in 49% patients, nausea and vomiting in 41% and dyspepsia in 19% of patients. In primary palliative care, oncologists and primary care specialists are there, inpatient units and OPD clinics are there, basic symptom assessment is there, basic symptom interventions are there, basic communication skills are there, complex cancer treatment decisions are there, basic end of life care are there and referral to palliative care services may be involved. And we expect increased expertise in palliative care in larger centers with the passage of time. In case of secondary palliative care, specialist palliative care teams are there as consultants, inpatient units and outpatient clinics are there, comprehensive symptom assessment and management is there, psychosocial and spiritual care are there and communication and decision making about advanced care planning and end of life care may be involved. And in case of tertiary palliative care, the specialist palliative care is the attending team, palliative care units are there, intensive symptom management is there, comprehensive psychosocial and spiritual care is there, complex communication and decision making about advanced care planning and end of life care is there. Often academic centers that facilitate palliative care education and research are also involved. How? OPDs, hospital based, IPDs, home care and hospice care, just to revise. OPDs, they have ambulatory patients, pain management, wound dressing is provided, counseling is provided, physiotherapy and occupational therapy is provided and symptoms that can be managed on OPD basis, they are dealt with. IPD or admitting within the hospital for acute episode of pain and other intraceable symptoms, bowel obstruction, palliative care emergencies, hypercalcemia, SVC, SCC, hemorrhage, respite care, palliative chemotherapy, palliative radiotherapy, dehydration and intervention pain management. In home care settings, it is meant for bedridden patient as per the desire of the patients. Home based hospice care is given, financial constraints may be there and there may not be any family support. Hospice care is given to patients having less than 1 year of life, all curative intent is over, symptom care is there, communication is aimed at acceptance, focus on unfinished task and final goodbyes, targeting at good death. Principles while delivering palliative care are to be followed. The palliative care delivery system should be realistic and sustainable. Patient's need should come first. This is not automatically the case. The success of the organization or department may be effectively the concern of the team. A partnership in care needs to be established with the patient. Doctors have no right to force decisions on the patient. Formal education and wisdom are not synonymous. A partnership in care needs to be established with the family. Enough trained nurses will not be available to give care for the patients. However, success is still possible by empowering the relatives to care for the patients. So, they act as caregivers. The family's finances need to be considered before advising on treatment. Existing resources should be utilized optimally. Constructing new palliative care centers is likely to exhaust available resources. Wherever possible, use should be made from existing facilities, that is hospitals and primary health centers. These are some of the references. Thank you.